underway. If I can get your attention. I would like to begin the program here. I have a couple of comments I'd like to make, and then we're going to have you have an opportunity to hear from our Medical Advisory Board, and you're going to have an opportunity to ask questions. We have 2 hours allocated to this event, and I think we'll be taking up the full 2 hours with their comments and their questions. But before we begin, I just want to say, I don't know if everyone understands that the Myositis Association has a 20-member medical advisory board. They provide guidance to us on a number of different issues. Certainly with regard to research, they're the ones who are making recommendations to our board of directors as to what the best research is to fund. They also provide assistance to the staff in terms of looking at some of our publications and making sure that the information we're putting out is accurate. We've also started a new program the last couple of years called the Visiting Professor Series, where we have members of our medical advisory board go to medical schools and do grand rounds teaching medical students and residents about myositis, hopefully encouraging them to take an interest in this disease. We've done about 35 of those presentations now at about 32 medical schools. And it's been a program that's been very well received, and hopefully we're getting more researchers and investigators interested in this disease. So those are just some of the things that members of our medical advisory board do for the organization. The other thing I want you to understand is they are volunteers. They don't receive any compensation. We pay for the travel to come to this meeting so they can speak to you. We gave them a breakfast a little while ago. And beyond that, they don't receive anything in return for their efforts. So I would like to ask everyone to, and I know you appreciate it, give them a round of applause. And thank you to everyone up here. I do want to introduce someone who is new to the staff at TMA. Some of you may have had a chance to meet her already. About 3 months ago, we hired a research director, and this is a position that's going to be working with our medical advisory board, writing for our publications, communicating to you about new developments in myositis research. She has many years of experience as a nurse. She's an educator, she's a writer, she's been working with the University of Virginia Medical School, lives in Charlottesville, Virginia, and Linda Cobert is her name. She's going to be moderating the panel this morning, so I'm going to turn it over to Linda.
Good morning. How are we doing today? So the way we're going to do this is, first we're going to let the panel introduce themselves to you, and then we'll turn it over to you all to ask your questions. So I'm going to start on this end and ask each member of the advisory board to please introduce yourselves, tell us where you're working, what kind of specialty you're working in, and a little bit about why you're interested in myositis and what your research interests are. So would you start, Dr. Jarjour?
Good morning. My name is Wael Jarjour, and I wanted to start out by saying you're a wonderful crowd, absolutely wonderful. It's a pleasure to meet all of you. I am a division director in rheumatology at Ohio State University in Columbus, Ohio. And I got interested in myositis because I was taking care of a very nice lady about 15 years ago, who developed the myositis right after taking Lipitor, a statin drug, and I got interested in this. So I've been doing research now in myositis for about 15 years. So glad to meet you all.
Good morning. My name is Mazen Damashki. I'm a neurologist. I'm the division head of neuromuscular disease at the University of Kansas Medical Center. I got inspired in thinking about myositis after my fellowship when I was a junior faculty at the University of Texas Houston Health Science Center, collaborating with rheumatologists. Yes, rheumatologists and neurologists can work together towards diseases, and looking at gene expression profiling in patients with myositis. So that was my first foray. In addition to learning how to do muscle biopsies, how to read muscle biopsies, it really kind of cultivated my interest in taking care of patients with myositis. So thank you for having me here.
My name is Dana Asherman. I'm at the University of Miami in rheumatology. I am not the director of my division. But I've had like many people here on the board, I've had a very long-standing interest in myositis, which is both clinical and research-oriented. And the research is, some of it is very sort of basic laboratory-based investigation, trying to understand the mechanisms of disease, at least in poly and dermatomyositis. I also have a strong interest in some of the complications beyond muscle disease and myositis, specifically lung involvement. And one of the things that we do at the University of Miami is we run an interdisciplinary clinic along with the pulmonologist, and involving me as a rheumatologist, where we see patients at the same time. And I think that that's seems to be something that's meaningful for our patients, certainly. One of the recurring themes that you'll hear down the line here is that many of us have had meaningful experiences with our patients, and I certainly remember the first patient that I ever encountered with myositis. And so even though I spend a lot of my time doing research now, it really does come back to you as the patient. It's something that is very much motivated by my interactions with people and not just mice. So you'd be glad to know.
Hi, my name's Tom Lloyd. I'm actually a neurologist at Johns Hopkins, where I've been for almost 15 years now. Really, what inspired me to initially become interested in myositis, and in particular inclusion body myositis, is when I was a fellow. So actually previously there had always been actually 2 fellows in neuromuscular medicine at Johns Hopkins, and actually my year there was only 1, which really gave me an opportunity to read twice as many muscle biopsies. And actually that year, they had actually double the number of muscle biopsies that they had ever had in any previous year. And the reason for that was, it was right after Andy Mammon and Lisa Christopher Stein had actually founded the Johns Hopkins Myositis Center. So it was really when I was a fellowship, and reading tons of muscle biopsies, and reading papers, and realizing how little we understood about what causes IBM, that initially really got me interested. And then over the last 5 or 10 years, it's really been all the wonderful interactions with all the patients that I've worked with, that's really motivated my my clinical as well as research.
Hi, good morning. My name is Chris Weil. I'm at Washington University in St. Louis, which is in Missouri. And I'm a neurologist, a neuromuscular physician. I see patients in clinic, but I also have a basic research lab. I'm principally interested in inclusion body myositis, but clinically interested in all forms of myositis. I think the reason that I enjoy seeing patients with myositis and enjoy that line of research is really just gets back to the fundamental issues of solving puzzles and trying to figure out what a patient's presentation is and what they have, as well as doing that in the laboratory. So I think it's a great mix to be able to see patients and then do basic research at the same time on the same questions. So thank you.
Hi, everybody. My name is Christina Charles. I'm a rheumatologist at the University of California in Los Angeles. And I became interested in myositis several years ago. Not a great experience at the time. I had seen 2 women referred from the pulmonary division who had very severe lung disease, and they hadn't been treated appropriately for their dermatomyositis, which had caused the lung disease. And it was at that time I realized that while UCLA had great programs in scleroderma, in lupus, and rheumatoid arthritis, they had no one really interested in myositis, and that had been for many years. And so it was at that time, which is now about 6 or 7 years ago, that I started a small myositis program at UCLA. And it has been fantastic. There is nothing that gives me more pleasure than seeing patients who are sick with dermatomyositis or polymyositis, and they do have early signs of lung disease, but seeing them and telling them that I can get them better, and watching them get better, and seeing them every week if I need to make sure they're getting the right treatment. So it's been a great part of what I do. I have done several years of research in atherosclerosis, in a different disease, in rheumatoid arthritis. We now have a research cohort in myositis as well of about 200 patients, and we are looking at the relevance of some of these inflammatory lipids to inflammation in dermatomyositis.
Good morning. I'm actually very different to everybody else because not only am I not a doctor, I'm a physiotherapist. I also specialize in younger people under the age of 18. So it's a little bit different to everybody else. I actually first came to know about myositis very, very early on in my specialization with a young man called Mohammed who had juvenile dermatomyositis, and at that time was told no one could do any physiotherapy with him because his disease was still active. So a year later, I got given this young man to rehabilitate who had no muscles, no movement, and no life. And it took me a year of working with him twice a day, every day, to actually change that and give him back the ability to move, to run, to walk, to go to school, and to have his life back. And from that, I thought that cannot have been the right way of managing the physiotherapy. And indeed, it isn't. So for those of you who have heard me and speak already during the conference, you'll hear I'm a massive advocate of exercise right from the very beginning. That's what we do in our unit. All patients with new onset JDM are admitted to our unit and have intensive physiotherapy. And from that interest, the medical team became super interested as well. And now we have a research center that looks at not only clinical research, we follow these young people over their disease course, and we've now got data for over 10 years of following these young people. We also have basic science research, and then we also research into a very rare group of adolescents who have all sorts of challenges added to them. And so that's where I work, both clinically and within a science setting. So thank you.
Hi, my name is Namita Goyal. I started my career at Mass General Hospital in Boston, and the reason I became interested in myositis is because one of our patients under our care was waiting for a muscle biopsy by the Department of Surgery at Mass General, and the surgeon had not prioritized her biopsy as an important surgery for him. And so unfortunately, her biopsy was delayed and her disease progressed to the point she needed to be hospitalized. And I thought that was really unfortunate because if she had gotten her biopsy much sooner, I'm sure she would have gotten optimal treatment earlier on in the disease. So my division chief and I went to the Department of Surgery, the chief of surgery, and we said, if you train me in doing muscle biopsies, I'll take all the muscle biopsies off the Department of Surgery's hands. And that was one of the earlier times that I then started doing muscle biopsies and started caring for all the myositis patients. Since then, I've become very interested in clinical trials in myositis. So not only the standard treatments, but looking at other treatment options and better treatments for our patients with dermatomyositis, IBM, and polymyositis. Thanks for having me here.
Good morning. I'm Marianne de Visser, a neurologist from the Academic Medical Center in Amsterdam, the Netherlands. I'm a newcomer on the advisory board, and I'm very much excited that I'm able to serve on this board. I became interested in myositis about 20 years ago, and there are two reasons for that. The first one being that the variability of what we call the clinical pictures, which means the distribution of muscle weakness, the severity of muscle weakness between the patients with myositis struck me. Even within the categories of dermatomyositis or polymyositis or IBM, there can be considerable differences. So I decided to devote my time on that, to do clinical research on that, and compare and make a comparison with findings in a muscle biopsy. And the second reason is that I noticed that we could do much better with regard to treatment. I saw too many patients who either progressed, deteriorated, their muscle strength kept deteriorating despite all the medication we gave, or they were better and came back a couple of months later because they had all the symptoms had come back. So we decided to start a trial, and unfortunately that was not the magic bullet. But I decided that it was very important to embark on new trials and to participate in trials to see whether we could find better treatment with less adverse events, events, as we all know that prednisone has. Thank you for having me here.
Good morning, everybody. So I have a very long South Indian name. It's called Kanya Boyina Nagaraju. So I go by Raju. And so Sue said she's different from others. I'm actually very different, partly because I'm a veterinarian by basic training. And then I did my PhD in immunology. And I got interested in myositis partly because of Dr. Paul Plotz, a rheumatologist who worked for a long time on myositis. So when I was about to choose the topics for my research, he told me, Raju, if you have to uncover the secrets and mysteries of autoimmunity and autoimmune disease, myositis is the disease that you have to focus. That I have been following his advice for the last 2 decades and hope to continue to do that for the next 2 more decades at least. So my basic interest is to understand how immune cells damage muscle and how muscle interacts with the immune cells. So this process is very complex. And so during this process, as you all know, that prednisone works, but it has terrible side effects. So we stumbled on drugs that look like prednisone and for last 10 years work to remove the side effects, reduce the side effects so that only the beneficial effects still remain. So this drug, from the discovery till now, it is in the phase 2 human clinical trial. The hope is one day we will get rid of the terrible prednisone side effects. So I'm really excited, and hopefully that will happen soon.
Good morning. My name's Steve Yetterberg. I'm a rheumatologist at Mayo Clinic. Uh-oh. We'll be out there with the cash in a minute. But Raju's a hard act to follow. I'm a simple clinical rheumatologist. I see lots of patients at Mayo that keep us busy. I got into this field, got interested in myositis when I started my fellowship in 1980 at the University of Michigan, and happened to end up in the lab of somebody who's a virologist by training. And we got interested in looking at virus-induced models of myositis. And I spent a few years in the lab, and that wasn't going anywhere. And now I get to have much more fun seeing patients than mice, and have the opportunity to work in a clinic that gives me the chance to see lots of patients. Like I say, they keep us busy, and to have access to people with expertise in other fields, like Dr. Maloney, who you'll meet next, and it just makes work fun. And I'm happy to be here with all of you. Thank you.
My name is Margarita Melone. I'm a neurologist, and I'm interested in muscle diseases. My original interests were in hereditary muscle disease, but then my interest shifted towards myositis when I started seeing patients who were referred to me for muscular dystrophies or for ALS. And indeed, they had an autoimmune muscle disease, for example, dermatomyositis or statin-associated myositis or inclusion body myositis. I'm also a muscle pathologist, so I have the privilege of seeing the patient in the clinic and then seeing their muscle biopsies. So I'm interested in providing the patient with the best diagnosis to be sure that they get the chance to be treated after making the right diagnosis. As Dr. Ritberg was saying, working at Mayo, I have the privilege of getting the benefit from the rheumatology group, so we work in collaboration. And thank you again for letting me be a part of this group.
Good morning, everybody. My name is Helena Alexandersson, and I am a physical therapist from Stockholm, Sweden. I've had an interest in myositis for more than 20 years now. I saw my first patients, and I have never heard of myositis, so I went to the literature. There were no publications about exercise at all, so I went to the textbooks, and they said, I could read, you should rest. You should not exercise, especially not if you have an active disease or in a flare. And together with Professor Inge Lundberg, who is a rheumatologist, we wanted to challenge this notion. And with grants from for rare diseases, we developed the first exercise programs, and we tested this in a systematic way. And it has been a fantastic journey for me to see exercise becoming a really important part of the treatment. And I see it's been fantastic for the patients too, who can do something for themselves. It's a treatment that it's a way to get control over the disease and a way to get better. And I'm really happy to be here with all of you. I find that I learn a lot discussing with you about your experience of exercise and from living with myositis. So thank you for having me.
So my name is Andy Mammon. I'm at the National Institutes of Health where my lab is, and I also continue to see patients at the Johns Hopkins Myositis Center. In fact, that's really exclusively where I'm seeing patients. I first got interested in myositis like Tom Lloyd, and I apologize about all those muscle biopsies and what a burden that was. But when I was doing it, there were fewer, but that's also what got me interested in myositis, was seeing the muscle biopsy specimens and realizing how little we knew about myositis, and it was, very interesting. And along with Lisa Christopher Stein and Sonia Danoff, a couple years later, we started the Johns Hopkins Myositis Center, and then it was great seeing, all of you and other myositis patients in the clinic. That was exceptionally helpful because you learn a lot more about it. I mean, you really learn the important stuff by seeing patients. And, one of the things that struck me, like Marianne, was that even within a group of patients that are maybe all called dermatomyositis, that because they have skin involvement, that there are really different subsets of patients that may actually even be different diseases. And so we've been very interested, along with others here, in trying to define, as well as we can, the different subtypes of myositis, whether it's necrotizing myositis or different subtypes of dermatomyositis, because we think we need to understand what the subtypes are in order to define the disease mechanisms in each subtype, and ultimately figure out what the best treatment's going to be for each individual patient who may have a different subtype of disease. So that's one of the things that my colleagues and I have been focused on over the last, I guess it's almost 10 years now. So thank you.
My name is Steve Greenberg. I'm a neurologist. And for the last 15 years, I've worked on all forms of myositis, but particularly dermatomyositis and inclusion body myositis. My interests have been in understanding the mechanism of the disease earlier on in my career, and for the last 5 years or so, I've been more focused on developing diagnostics, improving the ability to diagnose the diseases, and developing therapies for them. Thank you.
So we have a fair amount of time here to answer your questions. So let me remind everyone that we are streaming live over the internet for those patients who aren't able to be here. We may even be able to take some of their questions as we go along, but that means that we want you to be using a microphone when you ask your question, and there are a couple people who have those in their hands, and if you raise your hand, we will get you a microphone.
Hi, my name is Phyllis Lowinger, and I'm from New York, and my husband was diagnosed with IBM. I've been speaking to a lot of new attendees here with IBM, and what I've been surprised about is that they've had their diagnoses by biopsies, and given that there's a blood test, which my understanding is as effective, I have questions about that. My husband had 2 biopsies, and from a patient point of view, a biopsy is a much more intrusive medical procedure than a blood test. So I wondered about that, and I guess, what kind of education is the society doing in terms of educating doctors about this diagnosis coming from a blood test?
Andy? Steve?
So Steve's being modest and not answering this question because he's the one who, one of the groups that developed the blood test. I guess what I would say is currently the diagnostic guidelines for how patients what patients should undergo to get a diagnosis of inclusion body myositis involves usually getting a muscle biopsy and physical exam findings, and currently we don't have a set of diagnostic criteria that include that autoantibody test. That may change in the future, but that's something that we'd have to actually look at in a very systematic way to determine in which patients we might be able to substitute the blood test
or some other testing for the muscle biopsy. I don't know if, Steve, you want to comment further on that.
I think that's right. There's no consensus in the field yet over the exact utility of the blood test. I think it's going to take a little bit longer for different groups to see how it performs in their hands and their opinions. I think my own opinion is I think at some point the diagnosis might be clear enough to many people without any testing, but I think in the interim, the blood test has a definite role, I think, in people who've had a muscle biopsy, but it was non-diagnostic in a certain way. And the blood test can be helpful, I think, when positive, but it's not helpful when negative. It doesn't exclude anything when negative, but if it's positive, I think it's a helpful test.
Then if, and I speak for my husband and other people with IBM, if I came to a doctor, I would like a physical exam because there are ways to diagnose IBM, the asymmetrical, and again, it's not 100%, but I'd like to be offered that blood test first. And if it comes back inconclusive, I'd open myself up to a biopsy.
Yeah.
Somebody over here? Great.
This one's really for Dr. Greenberg. I was wondering if you'd elaborate a little bit more about the large T-cell paper that you put out. And I'm currently in the process of going through that diagnostic. And my hematologist had asked me if I was ever told I was anemic. And I said no, and he's like, well, you probably don't have it. But I didn't see anything in your paper as to whether the people that you included in your study, if any of them had been told they were or were not anemic before you did the tests on them to find out whether they had the large T cell.
Yeah, so you're referring to a recent observation that the majority of patients that I've looked at with inclusion body myositis have a detectable blood abnormality, which consists of an expansion of a type of T cell, and that this overlaps when these expansions are significant enough. The hematologists have generally diagnosed such patients as having a form of leukemia. And so your specific question about whether patients with IBM who have this overlap can have other blood manifestations of this leukemia. I didn't publish that or discuss that in that paper. There's a previous one where I'd made that observations in some patients. But so amongst the series that I did publish, there's about half a dozen or so patients who had quite substantial anemias, hematocrits in the low 20s, for example, and white blood cell counts who have been under the care of hematologists for that. So it does occur, I think, when we look at people with IBM at their blood more closely, there is a greater than age-related decline in blood counts in a significant population of patients. I think that also is not, I think it's important that other people in the field develop experience with that and publish in this area their experiences as well, but that's been mine.
Thanks.
This question is for Dr. Christina Charles. I'm very interested to hear more about your studies and correlation of dermatomyositis with lipids, perhaps as acute phase reactants or indication of disease. It certainly could be coincidental, but when I'm not feeling well, if I have my lipids checked, they're usually rocketing up there. Anyway, and then I had another question, and then I'll sit down and be quiet for the physiotherapist, that when I have gotten fairly healthy as far as my physical ability to walk and to do things like that, all of a sudden when I had a flare due to extreme stressors, I went downhill, even with the same amount of exercise or more, and the fatigue was huge, and so I was kind of, caught in a catch-22 situation. So comments on those would be welcome as well.
I'm so excited. You're excited about your cholesterol. This is great. I never get any questions about that. So we all think about cholesterol as related to heart attacks and hardening of the arteries, so to speak. But if you inject mice with LPS, which gives them a nasty infection, cholesterol levels drop. They're kind of negative acute phase reactants. So a lot of times when, and we haven't published this yet in myositis, but we've done a fair amount of work in another inflammatory disease, which is rheumatoid arthritis. The disease is very active. Cholesterol levels tend to decrease, both the good and the bad cholesterol. You're telling me the opposite, which is interesting and I haven't seen before. But in your case, everybody's different. Now, you're not eating differently when you're feeling bad, are you? Okay, so that's not it. Again, we're seeing trends in myositis. We haven't published it yet, but that inflammation and inflammation measures in a disease like dermatomyositis is different than measuring inflammation in other disease like rheumatoid. So maybe we won't see what I think we will, but so far it looks about the same. Your question about dermatomyositis and what we're looking at in terms of lipids, if you look at muscle and even skin in patients with dermatomyositis, there's a lot of inflammation around the blood vessels. And high-density lipoproteins are carriers of the so-called good cholesterol. And they have a large role in protecting the blood vessel from damage from oxidized LDL. And so we're seeing some abnormalities in the HDL from patients with dermatomyositis that may be somewhat relevant to the disease as therapeutics get developed to improve the function of HDL and improve its ability to kind of mop up these oxidized lipids, which can be very inflammatory to the cell wall. So that's what we're doing. Hopefully we'll publish soon.
Regarding your question about exercise when having a flare, I think it's important that for everybody that the exercise is feasible and doable in your daily life. So if you experience that during a flare that you get more fatigued and more muscle weakness, I think you have to adapt the exercise program and maybe go start with this home exercise program that has been tested and it's working for if you have an active disease. So you go down in intensity, maybe do shorter exercise sessions, but maybe more often, so that it was still working for you. I think it's important that you keep your exercise habits, even though you're able to do less, so that when you come out of the flare, you still have this exercise habit and you just start to build and progress to exercise again.
I would just say I would agree with that entirely, that actually when you've got a flare, it's just as important to exercise as when you are in remission, in order to try and make sure that you don't allow the deconditioning of the good muscles to happen as well while you're waiting to get better. So keeping, exercising, especially focusing on muscles that aren't affected, is also going to be super important to minimize the negative effects of the flare.
Thank you.
Yes, my name is Tom Cox, and I have IBM. And let me preface this by thanking you for volunteering your time to be here and doing this important work. As you introduced yourselves earlier, I was struck by the number of times you used the word diagnosis vis-a-vis treatment. And as someone who has the diagnosis and has seen neurologists, rheumatologists, when I go and when I leave, I almost feel like it's been a waste of time because I go, they confirm what I already know. So I guess I'm looking at it from this esteemed group here. You're on the vanguard of what's happening out there. Is there anything that's exciting you today, not from a diagnostics bent, but from a treatment bent for IBM? We come to these meetings and it's kind of the same thing every year, and you just gradually go downhill, and what have you. So I'm really hoping that we can hear something that is promising out there that you may be aware of or you're working on yourselves. Thank you.
I know that, treatment of IBM in the sense of reversing the worsening in the disease or slowing down its rate of progression has been a holy grail that all of us have been very keenly interested in, because IBM stands out from polymyositis, dermatomyositis, and necrotizing autoimmune myopathy as the one that's the toughest to manage. So we typically recommend currently in the clinic things to conserve strength with physical therapy of the type that's appropriate to the weakness. And I'm not a physiotherapist, but it's not the intense physical therapy that you would get after stroke rehabilitation or during the course of traumatic brain injury rehabilitation. But we need something more, something better, not as a substitute, but as a supplement to the physical therapy that people should engage in. And Dr. Alexandronson had published several of her work on small case series of exercise in people with IBM, showing how a mild to moderate intensity exercise is safe and could maintain strength perhaps for a longer duration of time in people with inclusion body myositis. Now, all of us were very excited about the BYM 338 program, and I can't speak for it, but we all have heard the public announcement about what the drug company had thought the outcome of the study was, and that's been a disappointment to all of us physicians as well as the IBM community of patients, I'm sure. So it's hard to be excited about things in the current climate of disappointment. We have done some work, some preliminary work that shows that a drug might be safe in IBM. So far, in a small number of IBM patients, we're interested in exploring that drug further to see if it actually does work. We don't know that. Should we be too excited? No. Should we be pessimistic? Probably not. We just have to be realistic. The trial is the trial. It just tells us, is this drug worthwhile in people with IBM? That's all it is.
Anybody else?
I can, sure. I'm working on this problem, so I've been focused on therapeutics for a couple of years. I was very involved in the BYM 338 program, which is someone else's drug. That's not a drug that was ever designed to address the problem with IBM. That was a drug that can build muscle up in anybody. And that trial did show that in patients with IBM, there was a sustained, prolonged effect of increasing muscle bulk that was dose dependent. That was a very significant response of that trial. It hasn't been published. So we do know that we can build muscle with that drug in patients with IBM. It didn't translate in the study into a meaningful benefit in terms of walking abilities in that study. So that's why I presume that's why the company discontinued development. But separately from that, it is a problem I'm working on, and I have developed what are called lead compounds that I believe would show efficacy for IBM. I'm a ways off from that, and I don't like to promote hope over this. I like to deliver results, but in answer to your question, it's something I'm working on.
I would like to make a comment on your observation about the fact that diagnosis has been underlined by many of us. The diagnosis is always the starting point for treatment of a patient, and you'll be amazed to know how many patients we see in clinic who come with a diagnosis of a myositis, treated for many years with steroids and other immunosuppressant drugs when indeed they may have inclusion body myositis. So the diagnosis is the starting point so that researchers like Dr. Greenberg, other physicians like Dr. DeMacci who ran a clinical trial are sure that they enroll in their study and they test the drug on the right patients.
Sure.
So I'm going to try to be a little more hopeful and positive than the previous people. I think it's been fantastic. So just the fact that there have been now 2 clinical trials, the arimoclomol trial that Dr. DeMacchi was talking about, the Novartis trial, even though it failed, do you know how much we learned in those trials? So failure does not mean that we didn't learn anything. We learned how to design a trial. We learned how many patients we need to enroll in a trial. And now the next trial can be done. We can know what outpoint and outcome measures we need. So I think that we can look at it as a failure, but I don't think it was at all. And I think it's really, you know, Dr. Greenberg, just by alerting Novartis that this is a drug that they had that would work for IBM is a huge, amazing thing that happened. And so I'm not as down on the therapies that are out there. I think we're increasing awareness for IBM, we're improving diagnosis, we're understanding the natural history, and that happens whenever trials are designed. So I think it's exciting.
Thank you.
So I think what I'm hearing right now, just to get closure on this, is that there's really not anything from this panel that you see as a breakthrough today or anything that really offers hope in the immediate future. And that's kind of what I've heard, is that yeah, we're getting better diagnostic tools. We are doing some trials and we are learning from those, but kind of the bottom line is that today there really is nothing that you're seeing out there that's a breakthrough for IBM. I'd love to hear something else, but that's kind of my takeaway from what I'm hearing now. Is that kind of, am I in alignment with you?
Yes.
Dr. Greenberg, is it possible to have IBM when your muscle biopsy comes back showing the inclusions and your blood test coming back negative?
Yes.
Well, that was short. Go ahead.
Hi, my name is Melissa. Have you experienced anyone with DM that's already been aspirating food because, you know, the stomach acids that's coming up, where there's like a procedure that would solve the aspirating food? I know, like, if you didn't have DM, you would do a fundoplication, like a Nissan fundoplication, but with DM, you can't do that because it would prevent them from swallowing or eating food. I know there was a recommendation of doing a toupee or a door fundoplication, but I don't know if you know anyone who's done that on a patient with DM or if there's any other solution to that.
I think the question I first have is the aspiration a problem because the muscle is not working? Is the DM still active, right? The esophageal muscle is just not working. Yes. And if that's the case, then the DM has to be treated more aggressively to improve that muscle function. There are overlap syndromes where there's something called a patulous esophagus and there's components of scleroderma and it's not just pure muscle. So if that's the case, it's a little bit different. And then if you have a good GI specialist to look at different pro-motility agents, small bowel overgrowth syndromes and bacteria in the bowel, that also, all those things need to be looked at if that's the case. But if there's also a component of muscle weakness, one of the problems I find most often when I get referrals from other rheumatologists is they just don't treat aggressively enough for the disease and they don't use multiple therapies in combination. Hopefully that helps. She's nodding with the scleroderma patulous esophagus comment. So.
Yeah, I have scleroderma as well.
Yeah.
So it's a combination with the distended esophagus and hiatal hernia. But I receive IVIG and rituximab along with flutamide because I also have ILD. But my infusion nurse, and please don't fall out your chairs when I ask this, but my infusion nurse recommended or suggested a poo transplant. A lot of people have not heard of this, but she's actually been a person who's donated her poo, and they put it in the capsule.
We're getting excited.
And she told me whenever I'm ready, I can have hers. But But because of the leaky gut syndrome, they said that often that you just need to realign your digestive system, and if you was to put a capsule of someone who's healthy and don't have any underlying ailments inside of your digestive tract, that it can go through and heal it. And there has been studies in the past that people have had miraculous healing from doing this. And her mother actually went through it, and within hours, she was changing. She was on her deathbed, and she's actually is walking around fine right now. So has anyone heard of? I don't know the term.
So that's very successful in bacterial infection with C. difficile, where treatment with somebody else's, excrement has been very successful at clearing this bacteria when antibiotics don't even work. I think you have to be very careful about, assuming any certain treatment is going to work for your case, and those studies have to be done in, your disease to make sure that that's a treatment. And also the GI specialist who's had experience with complicated cases, and that's so important. In addition to working with your rheumatologist or neurologist in treatment of your disease, a good GI specialist. And we have people, at UCLA who specialize in treatment of GI-related disease with scleroderma, for instance, and they've had that experience, and they can really give some better insight into treating your disease. I think that's crucial. I wish the poo pill would be cure-all for everything, but I'm not convinced yet, okay?
Okay, that's what I wanted to hear. Thank you.
Go ahead.
Oh, me? First, I have two questions, and for two different doctors. The first question, and I would also like to thank him as well, is for Dr. Andrew Mammon. Hi. Thank you so much for letting me and my primary care physician, Dr. Miranda Hart, bombard you with emails and questions for my disease. I'm Nikita, all the way from Chicago, Illinois. I'm sorry for waking you and disturbing you while you were trying to sleep, but I thank you. I was diagnosed in December of 2013 with polymyositis, but I also have the antibody, which is the SRP antibody, and I was discussing that with Dr. Mammon, and he suggested methotrexate. Now they've given me the Rasuvo, which I found out is like the liquid form of methotrexate. So I do the injectable, and they're trying to wean me off of the prednisone because of the nasty side effects. But just 2 weeks ago, I was also diagnosed with the ILD, which is the interstitial lung disease. That one.
Very good.
So I'm trying. So great. It's like I'm trying to see, is there like a certain test where I can tell like my doctor, whether it's my neuro or my rheumatologist or the endocrinologist or the otolaryngologist guy, which is the ear, nose, and throat. I'm trying to see, is there like a certain test that they can do, like a blood test that they can do to kind of figure out if my lung disease is caused, like a side effect or something causing it's getting worse because of the methotrexate, because the Rituxan and the rituximab and the plasmapheresis and none of that seems to have worked. So I'm trying to see, now we have to treat not only the myositis, we have to treat the lung disease as well. So I just want to know if there's a test for that, so I won't have to get another muscle biopsy or a lung biopsy. I don't like to be stick and poked, I'm sorry. And then my second question, I'm sorry if I mess up his name, I do apologize, for Dr. Nagaraju.
Perfect.
Very good.
Because I know he was talking about the prednisone and the nasty side effects, because I found out through my own investigation that I have what's called steroid-induced Cushing syndrome, because my neurologist didn't catch it, my rheumatologist didn't catch it, But when I started getting fatter and fatter and fatter and had the full moon face and the cow hump and everything like that, that's when I knew that I had it and brought it to my doctor's attention, because I was being my own advocate. So I was trying to see if there's like other medications or clinical trials that will take the replacement of the prednisone, so therefore that I can get off of the prednisone completely. Sorry if it was too long.
So no, it's nice to see you. I think we have had some emails back and forth. So the patients with the anti-SRP autoantibody that you have, usually the main problem is muscle disease, but probably about 20% of patients with anti-SRP can also have interstitial lung disease. I think the point of your question is, how do I know whether the lung problems that I'm having are due to the methotrexate, which would be solved by stopping the methotrexate, or is it an autoimmune process and we actually need to be more aggressive about treating that? I'm a neurologist. I know a little bit about lungs, so I have to deal with it, but really that would be something I would want to address with my pulmonologist. It's an important question to figure out whether the lung disease is a problem because of the medication, or whether it's because of your underlying autoimmune disease. And I think the second part was, is there a simple blood test to answer that question? And the answer is really no. I mean, with the muscle disease, especially with the necrotizing myositis, we have a marker, the CK, that is one of the things that helps us decide whether the disease is active and so forth. But there's no simple blood test for ILD to determine whether it's from the methotrexate or something else. But it's an important question to work through with your doctors, for sure.
So regarding the so-called dissociated steroid, so it is in clinical trials. So we just completed the phase 1 clinical trial. That means it is safe. And then now we just started phase 2 clinical trials, but these clinical trials are currently being done with children with Duchenne's muscular dystrophy, and the trials will be completed in another 6 to 8 months. Then we will come to know the drug. We know now it is safe, but we need to know now whether it is efficacious in people with the disease. So it may take probably another year and year and a half to get an approval if everything works in a trial.
So the question is, which trial is it?
Oh, currently there is no trial in myositis patients. The trial is being done in children with Duchenne's muscular dystrophy.
And what's the drug?
Vamorolone. I would be happy to give you more information. I think I can update you periodically too. So.
Thanks. Do we have somebody here?
I didn't attend last year, but I want to know, within the last 2 years, is there any new work, has any new work been done? Should we or should we not take the flu shot? Thank you.
Good question. Yes. Who wants to answer that?
Yes. So yes, exactly. The short answer is yes. There's really no risk in getting the flu shot. I know that there are some, at least theoretical, concerns about activating the immune system and perhaps triggering a flare of myositis, but there's really no evidence for that. It's not a live virus, so even if you're on medications which are suppressing your immune system, you're not at risk in any way. So it's very important, particularly for individuals who do have lung disease, that it's very important to do everything that you can to prevent superimposed infection. And while the flu may just be muscle aches in some people, in those who are immune compromised, there can be involvement of other organs, and particularly the lungs. So it's a very key part of what we call maintenance therapy. So as I said, the bottom line is yes.
I'll even go a step further. The caregivers need to get a flu shot. Anyone that's in close contact with the patient needs to get a flu shot. Flu shots aren't 100%, and we need to minimize the risk. So everyone needs to get a flu shot.
Thank you.
Okay, thank you. This is sort of a tangent from the poop question. My question was, is there any research going on to see if any of these diseases have a unique microbial biome fingerprint? That's my first question. And the other question is, if you have a patient like me, has DM, is perfect on paper, never had an elevation in anything except the muscle biopsy showed parafascicular atrophy. This was years ago. Now I want to assess where I am, and I'm continually on IVIG. What is my step to say, do I still really have this, or do I have something else, or where am I with this, other than just clinical presentation of weakness?
Why not? Hi. Me and the poo again. So I am not aware of anybody doing work yet, and please, anybody on the board, correct me if I'm wrong, with specific evaluation of the microbiome from patients with dermatomyositis. We have some work that was just recently published from UCLA in the microbiome in scleroderma patients, and so that may follow in DM, but I'm not aware of any group that's done it yet. In regards to your question about your blood tests in dermatomyositis, that is one of the most common problems I see in patients being referred or self-referring because they're told that they're fine. And a lot of my very severe active DM patients will never have an elevation in their SED rate, in their CRP. Their blood work looks great. They're told there's nothing wrong with them. And dermatomyositis, also in chronic disease, we know that the CK also is not elevated a lot of the times, even with active muscle disease that we can pick up on MRI. So that is an area of research that certainly needs to be pursued and that several people are looking at in terms of better biomarkers for active disease. In the absence of those perfect tests at the current time, you are probably your best lab test in terms of how you feel, how your muscles are, how your skin is, working with your rheumatologist or neurologist. And the other thing, in the absence of knowing how your gauge of disease is working with your doctor to say, hey, I think I'm doing really well. Can we wean slowly? The IVIG, for instance, a lot of times what I do is I pick off 1 day a month. If the patient's getting it 3 or 4 days a month, we see how they're doing with only 2 or 3 days. We go a few months like this and slowly try and wean off medication if we can, keeping close look at the disease and how you're feeling. I wish I had better answer.
Thank you. I have been working with a gastroenterologist, and we have traded out what he thinks are very safe probiotics.
Oh, yeah.
And I am so much better.
Yeah,
so we are sort of looking at restoring the microbiome.
Yeah,
so.
yeah.
Thank you very much.
I have another suggestion for you. You might, it might be helpful to perform a muscle MRI, because muscle MRI can show whether there is still inflammation, whether there is fluid that is visible on an MRI, and that in combination with your muscle weakness can probably tell you whether the disease is still active or not.
Thank you.
Hi, my name is Diana. I'm from Providence, Rhode Island. And I was just wondering, how on earth do we get specialists in Rhode Island to treat myositis? It's been a horrible experience. We've been refused treatment. They don't know what to do with us. I'm not the only one in the state of Rhode Island. I was lucky enough to get up to Boston Mass General Hospital. That's where I'm being treated currently. I've now tacked on 3 other doctors from Mass General Hospital. But it's a 2-hour commute between car ride and train, and it's exhausting. I was just wondering, how can we bring knowledge to these doctors who say they specialize in the disease and they really don't? I was very disappointed. I had a trip to the MDA clinic thinking that here, this was a great place to be and where I could get treatment. Unfortunately, I continually got brushed off to the point where I just left because I didn't trust anybody at that point. So I'm just wondering how I can, if there's anything that I can do or somehow get help in the state of Rhode Island. We need it desperately.
Maybe I can field that question. TMA is trying very hard to spread the word about myositis to physicians all over the world, in fact. And we can serve as a referral service for you. We can help you get connected with our medical advisors, who can then help your physicians be connected with your physicians so that they can have a conversation about what myositis is. So maybe you can stop and ask us, and we can help hook you up.
Okay. Hi. My name is Roger
Hi.
Mark, and I'm a patient of Dr. Lloyd's. And I saw him, I haven't seen him recently, but last May of 2015, I saw him. Then I went to the Orlando conference and met Helena and Sue up there, and basically I got a green light to go ahead and do the exercise. Now here we are a year later. So the base here is that I can walk for about 3 to 4 miles a day, and 4 of the days I swim for about 3/4 of a mile. At times I can swim for a mile in a day. So here's my question. I still fall. Especially when I do 90-degree, turns, I still fall. So recently, Dr. Asherman had put me in touch with Kevin Mills, who's a physical therapist that had worked with him. So the topic of oxygen deprivation therapy, I'm hoping I'm using the right term, for the muscles, where they tie the muscles, and there's been a study out of Brazil that I read, and there's quite a bit of going on, in other areas I've read. Does that help do you know what I'm talking about, the oxygen deprivation therapy? So if you can comment on that.
Can you do
So I'm actually going to hopefully defer to my physical therapy colleagues up here. I'm certainly aware of your situation and the interest in oxygen deprivation physical therapy, but I'll be completely honest that I'm not an expert in any way in that area, so I'm also interested in learning more about this.
I think there's two things, and I'll leave the oxygen deprivation to Helena, but I also think there's, only because she presented on it yesterday, so she's allowed, but I think there's also another thought, is that the type of exercise that you're doing is for the whole body, so you're using all of your muscles all of the time. But balance requires certain muscles to be very strong and very effective very quickly to be able to control, to avoid you falling. And it may be that you have other areas of weakness within your body that could be managed more effectively with very specific exercises, so that you could train these muscles better to respond better so you don't fall over, and therefore will help you be more secure to continue with your more generalized physical activities, such as your walking, your swimming, etc. So it's thinking about exercise in two ways. One of them, which you do beautifully now, which is about keeping you generally very fit and very strong, but you may also need to have a very specific program for areas where there are weaknesses, and your falling is actually just an indication that's where you need to focus next.
I have to admit I'm not an expert either in training during vascular occlusion, but I read there's one case report from Brazil where they present a case of a man with inclusion body myositis with muscle weakness, and he exercised, they put blood pressure cuffs around his thighs. And they inflict them so he only has 30% of his normal blood and oxygen supply. And then he performed leg press exercises on a much lower intensity, maybe 50% of the maximal strength. And in this case, it was well tolerated, and he improved his muscle strength in the quadriceps. Again, this is one case report. I know that there is a study, a randomized control trial going on in Denmark, and I'm excited to hear the results from this study. But the rationale for this I think would be that if you exercise with less oxygen, this will boost the muscle cells that they want to improve and grow. So you could exercise on a lower intensity than you would have to do if you had normal supply. You would have to perform really high load, high intensity resistance training, which might be difficult if you have inclusion body myositis. So I think that's the rationale behind this. But I hope maybe next year we can be able to give you the results from this Danish study.
Thank you.
Good morning. I'm Dennis Chatta from Minnesota. I want to start out by giving a little shout out to my clinician from Mayo Clinic who sits on the board. Yay for Mayo Clinic, 90 minutes from my home. But in addition, I want to thank all of you for making your expertise available in this open forum. I find it to be priceless. Now I ask for your speculation. Recently, you may have heard that a rather promising drug, possible drug for IBM, the drug trial was suspended. The question I have for you has nothing to do with that. I would like an opinion from the group. Do you believe that outcome, as you study the outcome of that trial, that outcome forecloses an avenue of research in IBM treatments, or is there out there on the horizon in the pipeline, as I say, other drug treatments that may be able to follow on to some of the things that were learned in that trial?
Dr. Greenberg?
I'll take that one. I think the main thing that was the most positive aspect of that trial was that the drug successfully increased muscle mass, the size of muscle, in patients who were treated with the drug. That was a very strong result that came out of the trial, and I hope that will get published and be the focus of a publication. I think that what that implies is that once a drug is developed that addresses the mechanism of IBM, the fundamental problem, which that drug did not, then the Novartis drug, if it gets approved for other reasons, would be a valuable combination therapy to help build muscle in patients once another therapy, in combination with another therapy that can address the underlying disease process.
Thank you. Do we have one over here?
We hear so much about diagnosis and treatment, and I thank you for that. But is there anyone working on a cause of IBM?
Anybody?
We have a few. It'd be nice to hear from a few people here. I think there are a lot of people who are working on the cause. It's my opinion that we'll never know a cause for it, just the way we don't know the cause of rheumatoid arthritis or psoriasis or eczema or any other autoimmune disease. The important aspect is to understand what is damaging muscle tissue and to be able to intervene on that. And we don't need to understand a cause for it, but really just what is the mechanism of damage. And there are numerous people on this panel and elsewhere who are working on trying to understand that mechanism of muscle damage.
Anybody else who wants to add to that?
I think at least what we think is it is unlikely that there is a single cause. There probably are several. That's the reason I think it is more important to focus on how the muscle gets damaged so that we can block.
But there are underlying factors. What is it that leads to the damage to the muscle? So for some of these diseases, there are clear genetic factors that are at play, but then that's not enough, and it probably takes something else to trigger those mechanisms that then damage the muscle. The cause is at several layers.
Thank you.
Hi there, I'm Steve Newman from Des Moines, Iowa. We also have a shortage of myositis expertise, but I am willing to travel to Mayo, so if you can use me as any sort of trial, I'll be happy to help. My question is, we have rheumatologists and neurologists, et cetera. Do you, as practicing physicians, prefer to be the point person? Do you prefer the primary care physician to be the point person? I understand it's a multidisciplinary attack to handle this. I'm having my primary care physician doesn't want anything to do with this. My rheumatologist is the one who's been doing this, but she's focused mostly on my CK level. The reason why I asked is because my MRI of my thigh and pelvis showed prostate enlarged, and my CT scan from my lung showed probable cysts on my liver, and nobody said anything about that. They're not talking to each other. As practicing physicians, do you prefer to be the point person, or do you prefer the primary care physician to be the point person?
So how do we manage patients together? Thanks.
So taking care of myositis patients, I think as neurologists and rheumatologists, we feel like we are the ones in charge of their medication management. I feel like I'm the one that should be deciding on the treatment options with the patient, examining them on a routine basis. I never prescribe a medication and say that come back and see me in a year or call me if there's any trouble. I feel like patients should have routine visits if it's every 2 to 3 months. If they're doing poorly, potentially even earlier. And if they're on a stable regimen, you know, within 3 to 4 months, but should be seen if they're on medications. I do use the help of primary care physicians, and I think they play a very important role. As many of you know, steroids have an ugly profile of side effects, and blood pressure, glucose, all of those medical issues do need to be managed on a very timely fashion, and that's when I do look at my primary care colleagues to help with that.
So, Dr. Yetterberg, maybe you can talk about how we would relate to the physician at the patient's home, since many of our patients are not where you all are.
Sure. No, I think it's a good point. Having, first I tell patients who live several hours from me, I can't be your primary doctor. You don't want me taking care of your blood pressure. You really need somebody at home. So looking at these cysts on the liver, doing an ultrasound to confirm that they're cysts, doing things to investigate the prostate, but you don't want me doing that. I'm just the rheumatologist, and having somebody who takes care of blood pressure is important. No, I'm very comfortable prescribing the immune-suppressing drugs, but you really want somebody who takes care of more hypertension than I. But it is maintaining communication with the person at home and getting records back and forth. At least that's my approach.
Dr. Lloyd?
So I'm a neurologist. So Steve's a rheumatologist. He had medicine training. I had little medicine training, so I would not know what to do with that. And I think that I really do rely on the primary care physician at the front line, because I am at a tertiary care center. I'm actually hard to get a hold of. I let my patients know that that I'm not responsible for emergencies. And that's not to say that I don't care about the patient. It's just that I don't have an infrastructure that allows me to get back. I don't have a nurse that takes care of things. I'm on my own as the physician, and so I want to make sure. So my biggest point is that that if somebody with myositis who I'm caring for has an acute onset of respiratory insufficiency and they call their primary care doctor and the primary care doctor says, well, it's probably because of your myositis, that's the wrong answer. You could have a problem with breathing for who knows what reason, and we need to have that looked at. So the front line has to be the primary care physician to rule out You know, you guys are all human beings, and you could have respiratory issues for reasons unrelated to your primary diagnosis of myositis. So I really do rely on the primary physician.
I would echo those sentiments and just basically summarize by saying that this really does require a team-based approach, and there's a role for a number of different physicians. And the point is that, just as you said, you're all human beings. This is not just an organ-focused disease necessarily, but this involves the whole person and multiple organ systems. And I think that everybody in that multidisciplinary team has something to offer in the overall care for you.
Next.
Yes, I'm newly diagnosed, so I do have some questions that might be minor to everyone else. But I've been diagnosed first with the interstitial lung disease, and then later found out that I had the polymyositis. I noticed that there's a lot of neurologists and rheumatologists. I don't know at what point do I need to get a neurologist. I do have a pulmonologist and rheumatologist, but I don't have a neurologist, so I don't know if that's necessary, or do you wait for some symptoms? Also, I have a second question, is that I never received a biopsy to get, they did I got a lung biopsy, but I never had a muscle biopsy. And I do have pain. I know with this disease, they say you have pain in your upper legs, but I have pain in my lower legs also, and I don't know if that's due to the statins or if it's due to the disease of myositis. I'm sorry, y'all. Do y'all get out of it? I was trying to talk fast because I know they don't know.
So we got it. I'm not going to, I'm sure there are other people that will weigh in here about whether you need both a rheumatologist and a neurologist. I think that, we have some difference in perspective, but the point is, I think that if you have either a rheumatologist or a neurologist who has an understanding of myositis and is interested in the disease, then you're going to be well served. I don't, at the risk of starting a debate here, I don't know that there's necessarily particular value of neurology over rheumatology or vice versa. I think that the other question that you raised is, if you have, let's say, interstitial lung disease, and that's in some way been linked to the overall disease process of myositis, do you also need a muscle biopsy? And I think that that's a very individual case-by-case decision. And really, from a common sense point of view, the way that I would look at that is, how is that going to impact your management? What information will we get from the muscle biopsy that maybe changes the way that we treat you? From an academic perspective, of course, we always want as much information as we can get, but sometimes we can make decisions even without biopsying every tissue.
Thank you.
First, I'd like to thank the board for their hard work and dedication. I am very concerned about the expense and funding for all of your research to continue and to expand. Is there any benefit as an organization and the people sitting in this room today to contact their federal and local Congress people and senators to bring awareness of myositis and to ask them to assist? I'm sure there's some committee in Washington that funds the NIH or tells them how much money they're going to have for the following years, but is that something that we as individuals can do to help with funding for your continued research?
I think that's extremely helpful.
I was just going to ask if you're for hire, so we need an agent.
We're on this side, right? Okay.
To be brief, I understand completely the comment from the board member about cause not being the focus, and we appreciate your strive for a cure. That's important to us. My husband, who has SIBM, but he signed up for a drug trial 5 years ago for an antiviral regimen that was probably going to kill him if that wasn't cured, and it was interferon and ribavirin. And he was kicked out of the drug trial when IBM weaknesses and symptoms and muscle biopsies confirmed he was an IBM stricken. But that doesn't bring the information to the other people, the drug companies, sorry, the insurance companies that are still pushing that regimen for Hep C victims. And so cause relationships to drugs like statins you'd mentioned, if this other information comes up, perhaps it will help someone else from ever suffering from the disease. Had you heard of a connection to antiviral regimens like that? They do run for 18 months, so you're under the drug interactions for a long period of time, and we thought it was a direct trigger.
Dr. Uterberg, can you talk about that?
So I can
oh, okay, great.
field this
Thanks.
one. So we're actually seeing a increased incidence of inclusion body myositis with a number of actually chronic viral infections. So it's more likely that Hep C as well as HIV are actually doing something to alter one's immune system, and that is what is actually triggering IBM.
Thank you.
And of interest, interferon alpha has been linked when used as a therapy for various diseases, for carcinoid syndrome or hepatitis C, to autoimmune disease, to generate an autoimmune disease. And in addition, interferon, type 1 interferons, interferon alpha, has been linked to autoimmune disease such as lupus and dermatomyositis. So, again, whether it caused, I don't know.
Thank you.
This is a follow-up question to the earlier one concerning the flu shot. What about pneumonia shots as well as shots for shingles? I happen to have myasthenia gravis, and my doctor had said absolutely no shingle shot. Fortunately, I already had it before the disease. So I'm curious on those two additionals. What about the myositis community? What should they be concerned about or not? Thank you.
So first, with respect to the pneumonia vaccine, which is now a combination of something called Prevnar and Pneumovax, again, there may be general reasons independent of myositis where that vaccine is appropriate depending upon age and other risk factors. Certainly, if you have lung disease, that's an important part of the armamentarium to prevent infection. And because it's what we call recombinant vaccine, it has nothing to do with a live organism, completely safe and very important. So I would put that sort of in the same category as the flu shot as something that is a key part of health maintenance. The shingles vaccine is actually on the other end of the spectrum because it is a live virus. It's a weakened virus, but in those people who are on various immune suppressing medications, there is some concern that giving that vaccine could actually lead to an attenuated or a weakened or altered type of shingles. So we generally would not advocate that once you're already on immune suppressing medications, but even that is more complicated because it depends on what medication you're on. We can't make generalizations about all immune suppressing medications. So for example, methotrexate and even Cellcept may be okay, but we would say in people who are on so-called biologic agents, rituximab or TNF blockers, that's not such a good idea. So it's a little bit more of a complicated answer, and certainly better if that vaccine is administered before you're on any of those medications.
Thanks.
But with them, the issue is prednisone, right? But if on methotrexate, it's okay so long as the prednisone is low enough. And I think 20 milligrams is the usual suggestion. above that, it should be avoided.
Yes, I'm Janine Arpin. I'm from California, and this is my first conference. And I came in very angry and militant, and I'm a little bit more hopeful and stuff. But I wanted to talk about control, because right now it's my insurance company that has control. And I had been treated for 2 years with IVIG and rituximab, and the plug was pulled on me last October for everything. So now I'm back on high doses of prednisone. They want to start me on, well, whatever. They want to start me on something else, which is more of the baseline. And I just got a call from my endocrinologist who just fired me as a patient because I'm non-compliant, because I'm on steroids, and now my sugars are very elevated again. So I just wondered if anyone could talk about control. Right now I feel like I'm playing in a shell game. I was diagnosed with DM, but they put an RA diagnosis so I could get access to drugs. Now the insurance company is telling me, you're really DM, this is all off-label, you get nothing. So I just wanted to talk about control.
Hello. How about your rheumatologist? What are they doing for you? Because I love to talk to insurance companies. Boy, I love it. I make sure they let me talk to a doctor from the insurance company, but that's very important.
I'm her only DM patient.
Yeah.
I'm her only DM patient.
Yeah.
And my PCP says I can't even pronounce what you have. Don't talk to me about questions about what kind of drugs to take. And my rheumatologist is very intimidated because she had the plug pulled on several of her. She used to have several DM patients, several. Now she's just down to me. Her medical group has said, don't fight this. It's too expensive. We don't want to be picking up the tab for this stuff. So I'm out there looking for new doctors, or should I be? So I went to an immunologist because they thought they could get me immune deficiency diagnosis. Then I could get back on the IVIG. I have the wrong immune deficiency. So I'm back looking for new doctors.
Yeah, I mean, I think that's what it's going to take. You know,
Yeah.
I don't think you're going to be effective in getting your insurance company to make the decision to approve IVIG. You need help doing that. You need someone who's experienced in the disease, who can talk to the insurance company doctors and tell them, or even write a letter, which is sometimes even more effective, but the consequences without treatment.
I don't want to keep carrying on, but they've gone through resubmitting.
Yeah, they need
my
to talk
biopsy
to
was inconclusive.
they
My
need to talk to
CPKs
them.
aren't high enough. You know,
Yeah. They need to talk to them. They need to request a physician-to-physician peer review, is what it's called.
Well, that's why I just wanted to end with I'm hopeful. I've had some very nice people come up and tell me that they're ready to go to bat for me. So next time I show up in front of the medical board at the medical group, you're all going to be there, right?
Thank you.
I'm Joyce Olson from California, Escondido. And Dr. Greenberg, you mentioned that that IBM, I have an IBM, I have had 2 muscle biopsies. One was done 10 years ago and was sent to Johns Hopkins, and they sent it back and said it was insufficient. I have been going to Scripps all throughout the Scripps doctors, every one of them. My latest was the doctor, a neurologist who is switching to MS instead of MD. He didn't like MD very well. So anyway, getting back to you, Dr. Greenberg, you mentioned that you can have IBM as an onset. Could be, I mean, I was dying with aplastic anemia. That's what the doctors came up with, because my bone marrow, I had 3 bone marrow tests done within 3 months and 3 months and 3 months. That's 9 months waiting to find out if I had leukemia. And then they came up with aplastic anemia. And this one doctor was quite a scientist, and he had had a patient before me who the lady said to him, well, the anabolic steroids you're giving me only for a month. She said, I'm going to die anyway, so let me take them for longer. So she took them longer, and in 3 months, her blood started leveling off. And the same is true for me. My blood started leveling off after I took them for 3 months. Anabolic steroids called Danazol, D-A-N-A-Z-O-L. And he put me on the highest dose, and then he weaned me down. Within about 3 years or 4, I was off of the dose completely. And during that time, my muscles built up. I was able to go faster, hike longer, and do more awesome things than I had ever done in my life. And it was because of the anabolic steroids. The Danazol was wonderful for me, and it really saved my life. So then when I was weaned off for like 11 years, I didn't take it. And then I started getting muscle weakness where I was falling down like 22 years ago I was falling. I can remember many times falling, getting off my bicycle, falling in the ditch in Canada on my bicycle, and just falling because of, rocks on the road. I was going down a grade and I couldn't stop myself.
Well, maybe we can ask Dr. Greenberg to respond to your question.
I've been diagnosed with IBM.
Thank you.
Well, thank you for sharing that experience. I have occasionally seen patients with aplastic anemia and IBM, and there is an overlap between aplastic anemias and this other type of leukemia, which is more common there. But thank you for sharing that experience, and I'll keep that in mind for the next patient that I see.
Thanks. So we have time for 2 more questions. I know you've been waiting.
Hi, my name is David Kirkpatrick. I'm from New Jersey, and I was diagnosed with IBM in October of 2014, and immediately went to Johns Hopkins because I also have Cushing syndrome, and I have a GIST tumor, and I had lymphoma, skin lymphoma. Basically, my question is on treatment. Has anyone considered a hypobaric oxygen treatment for IBM, which I have? I had that treatment in New Jersey, and basically, right after the treatment, I did feel some positive effects from that. I think they have worn off by now, because this was late May into early June. And if you think about the cost, any large hospital center have these oxygen chambers, and they're not being utilized all day. So there's a technician who sits there not doing anything, and the oxygen the hospital has. So I had no ill effects from this. I have diabetes also, and my blood sugar had dropped 15 to 20 points while I was in the oxygen chamber for about 110 minutes. I did this for 20 days, and I was tested before I went in the chamber and after for sugar and for blood pressure. My blood pressure dropped about 20 points also in there. So I was just want to know if anyone has considered this type of treatment. And the other statement I want to make is that while I was here for the last few days walking around, I met a lot of people with IBM that were from smaller towns in the country. I think one from Canada. And when I talked to them about occupational therapy, they had a very negative answer because they felt they weren't getting any occupational therapy from their occupational therapist. And I'm very fortunate to have a very good occupational therapist in New Jersey. And I'm on a regimen of exercises 5 days a week. I have an Excel spreadsheet, and I do about 20 exercises at home. And any exercise that needs an apparatus, I went on Amazon and I bought that apparatus. That's the same ones that is being used by the occupational therapist. and I find that extremely helpful. And I told these people that I will send them that information. Unfortunately, I lost all the cards, so I hope they can give them back to me. And I can also show them what type of equipment to purchase, because they don't have that type of ability in their small little towns.
Thank you.
Thank you.
Do you want to talk about the OT stuff?
So I think it's amazing that you've taken up the whole strategy of having a very formalized exercise program and gone and resourced that for yourself, recognizing that that there are challenges in healthcare providers in what they're able to provide. I think, obviously, I come from the UK, and we have challenges, and those challenges are growing as well. And I think it is very much, you know, what you need is somebody to guide you initially, and for then you to take up your own responsibility for doing those exercises and those treatments for yourselves. It is much, much more difficult, clearly, doing exercise than it is taking a tablet. But if you think about it, you wouldn't expect a nurse to come and give you your tablet every morning. I guess it's the same thing with physiotherapy exercises or occupational therapy exercises, that once you're taught them, it's your responsibility to do them. They obviously time-consuming and require a lot more effort on your behalf. But if you perceive them in the same way as your medicines, then it makes it a slightly different philosophy, I think.
I was just wondering if this information could be put onto the website for people that don't have access to occupational therapists, hand exercises, that they can look at on the website and do it on their themselves.
I don't see any reason why Helena and I couldn't review the exercises that you have and then you've been given, and then we could add some of our own as well and put them on the website.
I would like to make a comment. We have a session today on bracing in IBM. And you know, many of you might have met Malin Regart, who is an occupational therapist. And she does hand function measurements for a study. So we're going to talk about hand exercise in that session, and we're going to post the hand exercise program that she has evaluated in polydermatomyositis. So that's going to be on the website as well.
Thank you. One more.
I'll be brief.
Thank you.
The question was asked a little while ago about what is going on to try and find what causes these diseases. I have IBM. The NIH has what they call a twin SIB study, and I have signed up for it. You're eligible if you have either a twin or a same-sex sibling within 5 years of your age. I have a brother who's willing to do this with me. So, and what they're doing basically is, you know, I spent 3.5 hours answering all the questions. I've had 9 tubes of blood drawn, no repeat biopsies, no repeat EMG as far as I know. But they're going to compare. I've got it, he doesn't. We grew up in the same environment with the same genetic background. And then, you know, hopefully something will come out of this. It's probably a needle in a haystack, but I'd like to think that I'm taking like 2 straws off that haystack.
Thank you. Thank you. So, thank you for all these amazing questions. It's very nice to have your input. So, thank you to all the panelists, too.
Just want to echo what Linda said. Excellent questions. We appreciate it. And again, very much appreciate all the efforts of our medical advisory board members. We're now headed to breakout sessions by disease type.